India is an endemic zone of diabetes mellitus, and sooner we are going to be the capital of diabetes mellitus of this world. So, diabetic retinopathy is a very important topic, not only for ophthalmologists as well as postgraduates. So, to give us the insight of such an important topic, I would like to invite Dr. Vinod Kumar, professor at RP Center AIMS. He's a brilliant surgeon, a loved teacher, and an avid researcher. He currently holds the post of professor at the very prestigious RP Center, New Delhi, and is a quite sought after international speaker. To you, sir.
Thank you, Uncle, for kind words. And at the outside, I would like to thank you for making me a part of this. We know that people are always gaga about Octa, and so what I am going to tell you is what has been our work on Octa in patients with diabetic retinopathy, and what is the current literature as to what it suggests, what we can do with Octa in current scenario. And third is what I feel is my judgment in today's scenario, what all we can do Octa in patients with diabetic retinopathy. So when it comes to diabetic retinopathy, we know that color fundus photography has always been the standard. OCT has revolutionized the way we look at diabetic retinopathy for past 2 to 3 decades. I think it's indispensable now. And fluorescein angiography always has been the gold standard for almost all the retinal diseases. We were limited by the view traditionally, but since the advent of ultra wide field imaging, I think the uh, fluorescein angiography images what we get in patients with diabetic retinopathy is awesome. What we get is it takes 2 to 3 minutes, but what it gives is indispensable. And I still continue to keep on doing ultra wide field angiographies in these patients. So I'll come to our work first. We compared this. We did this study around I think 3 years back, where we wanted to compare how does FA fare to Octa in patients with the diabetic retinopathy, and if we and we wanted to assess if there were any vascular changes which we could detect on Octa but were not seen on angiography. So of course this was a thesis given to one of our candidates. It was a cross-sectional study. We included eyes with patients with diabetes who had diabetic retinopathy and no diabetic retinopathy, and patients with diabetic retinopathy were further divided into non-proliferative and proliferative. So we collected all these patients. All these patients underwent fundus photographs, Octa, and wherever we could do FFA, we did, but we did not do FAs in patients with where there was no clinical diabetic retinopathy. So we compared, we did 3 into 3 as well as 6 into 6 and 8 into 8 scans, and initially we tried to assess whether we could see the various lesions which we traditionally see on that is microaneurysms, the size of FAZs, the CNPs, capillary non-perfusion, both in the mid periphery as well as the posterior ones, and then the other lesions we assessed as well. So I'll directly come to the changes. Now microaneurysms we know is the first feature of diabetic retinopathy, and we found that in Octa we could beautifully see the microaneurysms. And it is a traditional teaching that when in diabetic retinopathy you see a number of microaneurysms, you go on to do FFA and you will see many more. Okay, that is traditional. But the opposite happens in Octa. When we do Octa, what we see microaneurysms is much less as compared to what we see on FFA. Now that is little kind of contradictory, but I'll come to why that happens. So this is a patient, you can see there's a non-proliferative diabetic retinopathy. When we go on to compare Octa versus FFA, you can see there are many more microaneurysms which are visible on fluorescein angiography but much less visible on Octa. This is another patient, similar thing happening. You can see certain microaneurysms which we can see on FFA are not visible on Octa only. So why this happens is we don't know, but probably microaneurysms are low flow lesions, and that's why Octa is not able to make out the phase difference. Now one thing has to remember that even the color photographs, they underassess the number of microaneurysms as compared to FFA. What was different in our study, we found that even in eyes, where there was no clinical diabetic retinopathy, some of the microorganisms could be picked up on OCTA. So this is one such example. You can see clinically it looks neat and clean, there's no diabetic retinopathy, but once you go on to do OCTA, and this will happen only once you do a high resolution, that is 3x3 image, you will not see them on 6x6 or 8x8 slabs. So you go on to 3x3 and you will see some of these microorganisms are visible even in eyes without diabetic retinopathy. Another such patient, so that is keeps on happening that, but again because there was no clinical diabetic retinopathy, we did not do FFA to confirm if they were actual microorganisms or not, because FFA remains the gold standard for the diagnosis of microorganisms. Now coming to FAZ, I think a lot of work has gone into FAZ. When we talk about OCTA, people have studied lots about FAZ, how to quantify the circularity. So all these things can be done differently in the superficial slab as well as the deep vascular plexus. Now that is very different from FFA. In FFA you do not you cannot dissect between superficial and deep capillary plexus, so it's a combined kind of image. But in FAZ, when we see on OCTA, we can see superficial slab and deep slab. So initially people study both superficial as well as deep, but just to tell you in a nutshell, in today's scenario, if you have to assess FAZ, you assess FAZ on the deeper vascular plexus and not the superficial vascular plexus. That correlates better with what is going to happen subsequently to the diabetic retinopathy. So we determined FAZ size and shape in deep capillary plexus, as I mentioned, and we also found it, and subsequently other people have also shown that FAZ tends to be larger in eyes even when there is no clinical diabetic retinopathy. So that is again a useful tip we get from OCTA that shows that there are certain vascular changes which are happening in eyes even when there is no clinical diabetic retinopathy. And when again as Devesh mentioned, we compared the vascular density and perfusion density, and again it's a logical as well as a well established fact that as this severity of diabetic retinopathy increases, both vascular density as well as perfusion density, they go on to decrease, in a way notifying that the disease is progressing and ischemia is progressing. Posterior capillary perfusion, somehow we never pay attention in traditional FFAs because our field is very limited in OCTA. So we pay a lot of our attention in eyes with diabetic retinopathy when we look on OCTA. So these are certain eyes when we look at, you can see the posterior capillary non-perfusion areas which can be very well picked up on eyes with in OCTA. Now what happens is that because in FA we are not able to see and quantify, we really don't pay so much attention when we talk about FFA, but when these posterior capillary non-perfusions are quantified, we can see that the larger is the posterior capillary non-perfusion, higher are the chances of diabetic retinopathy progression. So again in our eyes, in our study, we found that in NPDR we had lesser number of eyes with posterior CNPs, and as we go on to PDR we had higher number of eyes with posterior CNPs. Now leakage is something which gives a huge advantage in patients with diabetic retinopathy. We can see which microorganisms are leaking. We can see sometimes which small neovascularization, which is very difficult to make out, can be easily picked up on FFA. But because leakage is absent, and especially in the larger slabs, it's very difficult to find neovascularization. So that is one thing we lack in OCTA. Peripheral CNPs again can be detected provided you have a wide field OCTA, but that is again I think in today's scenario at least we do not have good machines which can provide a single click a larger field OCTA. Neovascularization, if large, can be very well picked up, but again you do not get the kind of contrast you get in FFA, especially with the currently available machines. So this is montage of few such patient, you can see there is a neovascularization, you can see the CNPs here, but sometimes, especially if there are small neovascularization like a small tuft and you are not experienced, you can easily miss those. And this is the other eye of the patient. Again, you can see there are peripheral CNPs and you can see a neovascularization there. One advantage is with OCTA is that you can segment at the level of ILM and you can see these NVs are actually raised and projecting into the vitreous. That is one advantage of OCTA. Tells you which NVs are raised and which are flat on the retinal surface. So by our study, we found that basically microaneurysms were much lesser in number on OCTA. They are seen even in patient eyes without clinically visible diabetic retinopathy. FAZ is a good marker of progression of diabetic retinopathy, and neovascularization, especially not too peripherally, can be easily picked with OCTA. That is something what came out from our study, and I think most of the current literature does suggest almost the same thing. But in my opinion, especially in today's scenario, if you give me a choice, I would still like to go ahead and do ultra wide field FFA. If I just have a normal FFA, conventional FA, I probably go ahead with OCTA and not do conventional FA. But the amount of knowledge what ultra wide field FA provides is not currently not provided by the currently available OCTA machines. So another advantage of FA is that it is a dynamic process. It tells you about leakage from the phases which are there in FFA. It does tell us something about what is happening to the flow inside the retina. Because of the wide field nature of FA, we can see the peripheral CNP and NVs as well. OCTA is a very useful tool. I think this is the future. Once we start getting a full field kind of OCTA in a single click, that is the time when FA usage will decrease. As Devesh mentioned, I think in patients with macular lesions, we are already doing less and less of FFA because OCTA gives you a wealth of information in the posterior pole disorders. But when it comes to periphery, we are still limited by the field. It is a very useful tool. Even in patients with no clinical diabetic retinopathy, sometimes it can tell us what is going on in the retina. Early vascular changes are seen in patients with no clinical evident diabetic retinopathy, and as we go on to the higher grades of diabetic retinopathy, these changes do worsen, and it's a very useful tool for assessing the macular CNPs as well as the macular ischemia. Thank you.
Thank you, sirs, for giving us such a comprehensive review of OCTA on diabetic retinopathy. I have just
please, sir. If you allow, sir, one question that I like to ask you based on your study only, and we all have observed that when we do OCT angiography in diabetic retinopathy in the central 3 mm area, you see these beautifully capillary non-perfused areas in the posterior pole. Do you offer any treatment based on this? Do you laser those areas?
Okay, that's a very good question. Now, I repeated several times that we do see some changes even in normal looking eyes. So even if there are milder grades of diabetic retinopathy, we know that at least in today's scenario, we do not have any treatment. So even if you detect certain changes on OCTA, I think we do not have any treatment and we do not do anything. But it does show some insight as to what is happening in the pathogenesis of diabetic retinopathy. We always knew that diabetic retinopathy is a you can say vascular disease, but now we have evidence which shows that a neurological component is going on simultaneously. So I think with the OCTA-like tools, we can show that even the vascular changes happen before the clinical evident changes. So what is going to happen is in future probably we are going to look at a treatment which is going to retard these changes and possibly nip the diabetic retinopathy in the bed before it comes up clinically. But as of now, it does not change your management at all.
Second question, sir, regarding the field of OCT angiography, you said that you prefer to do ultra wide field FFA. Now with Dream OCT being launched, it is giving us a 130-degree OCT angiography in a non-invasive way. do you think it will do anything to change your practice? Because now you have a 130-degree field OCT angiography.
Uh, I still think I will go ahead with FFA at this moment. The reason being, I think we know that with ultra wide field, what one change happened is we know that there are two kinds of diabetic retinopathy. The one kind of diabetic retinopathy which predominantly involves the posterior pole, while the other kind which involves the peripheral retina. We call it predominantly peripheral lesions, and it has been shown conclusively that patients who have more peripheral lesions, they tend to progress more. So I think 130 degrees still kind of mid periphery, and we are not able to see the periphery. And one of the newer diabetic retinopathy protocols, they have shown that the FFA lesions which you see on periphery are actually more predictor of progression than the clinical lesions which you see in the periphery. So that is again very useful thing which have come from ultra wide field FFA. And I think once we have 200 degrees, then probably it would be good enough. And one thing I forgot to mention, it's very important. OCTA is very important, especially in eyes with diabetic nephropathy, because some of these patients who have high creatininuria, these patients cannot undergo FFA, and OCTA is extremely useful in such patients. No, there are. I think there are inbuilt protocols. You can mark the area manually. You can you can see the superficial plexus. Then you can mark the area, deep capillary plexus, and you can mark the area and calculate it manually. I think the newer machines have inbuilt protocols also, where they automatically detect the FZ and they will give you the size of the FZ.
So DRI OCT, when it came, say initially manually you had to mark the FZ. Now Spectralis, the latest software update, it gives a auto segmentation. So does Angioplex, probably Intelite. I have not seen their software updation.
Yeah. I think again, FAZ macular ischemia as such was given a lot of attention in pre-VEGF era. When we were doing laser, we used to talk a lot about macular ischemia. But with the onset of anti-VEGFs, I think we are not so much worried about the macular ischemia. And now I think we know that macular ischemia is a overhyped thing. It does not correlate with visual acuity so much, jitna ki we used to believe. Only if it is too large. Only if it is too large. Only if it is too large. Sometime if it is kind of medium term, I think medium term loss, then it's not so much correlating with vision.
I think other than the phase area, just I showed that it's the circularity index that has come up. So if the phase is, even if it is not circular, it is distorted in one part, it will signify as localized ischemia which is there. So rather than focusing just on the phase area, you may be interpreting erroneously sometimes.
Yeah, that is one problem with OCTA. I think the repeatability is little dicey as of now. The measurements are different for different machines. What you see, actually, we don't know whether it is true, because lot of software developments, what they do is they try to in trying to make the image look beautiful, they put in feed in lot of data so that the fill-in gaps are filled. So that's why a lot of these images will actually not show what is actually